we are live on air. Somebody's watching on Instagram. Thank you for watching tonight. This is NeuroThursday. We're going to be here every 14 days, starting 2 weeks ago. This is, I might say, episode number 2. And I'm happy to see some of you guys joining us again or joining us for the first time. So we can talk about functional neurology. This is what this video session is about, our NeuroThursday from our academy, to give you an insight into what we're doing here, what I'm doing in my daily work, in my daily practice. And this is going to be like some basic aspects. First, we're going to go through last time, this time. If you missed the first episode, we will have it on our website soon, but we already have it on our YouTube channel. It's called Neurolog Academy TV. And we have that posted there, so you can go back and listen to that. I will go back to the prior episode telling you about what I've been talking about last time and going into what I want to talk about this time. And of course, I'm going to try to have these separated so you don't have to like see all the episodes to be following. But of course, I'm going to kind of have a plan in my head, what I want to work through in these now 10 planned episodes so far. I think I'm going to probably extend that beyond the 10. But this is where we start, and or we started last time, and this is where we continue today. So, hello, I will give all you guys on Zoom the opportunity to talk to me directly at the end of the session, like we did last time, to do some direct question answer. Everybody watching on Instagram, if you want to join us on Zoom, you can find the link on our website, but of course you can stay on Instagram. I will not be able to chat with you, but I want to give you some, say I'm here, and you are there listening. That's awesome. Okay, so what are we going to talk about today? I want to talk about the question whether if somebody comes in, for example, with a knee pain or a hip pain, does he have like a sensory motor or somatic dysfunction, or does he maybe have an autonomic dysfunction? So that's one thing you want to think about. So we have different views, we have different people looking at these problems. Like the dentist would probably say, well, if you have a hip problem, we don't know where it's coming from, might be your tooth. We might have the Chinese medicine guy saying, well, maybe it's your liver, because your liver meridian is going over your hip and your knee, and that's causing some stress in that area, so it could be your liver. Maybe the biochemists might say the same thing. Sam, you have a toxic problem, and you want to maybe detoxify because the toxins are causing a liver dysfunction. So the biochemist and the Chinese guy might agree on what's going on. So here we have more an autonomic view. Then you have the osteopath and the manual therapist and the chiropractor, who might look at more the joints or the subluxations of the hip, or the SI joint, or the lumbar joints, etc. So all these things might be looked at, and one thing I think is that all these things should be considered. All these things need to be considered. So we cannot go and have a certain philosophy about, well, it's more like a joint issue or a subluxation issue, or it's more a toxic issue. These are all possibilities that can occur, and it's our duty to figure out what the problem is. And all of these might have to do with neurology, because that's where we want to start with the treatment. Detoxification, well, maybe your kidneys and your liver and your lung and your skin, all that is not innervated correctly or regulated correctly, so your detoxification is not that good. So that could be a neurological problem. It could also be an overload problem, so then you have to take care of the overload, meaning you have to change your diet or whatever is overloading your system, of course. So I think in the end, we need to consider all of these aspects. We need to consider every single thing that I just mentioned, and beyond that, of course, not to say, well, maybe the psychologist is saying, well, it's your stress that you're having every day that's causing your hip problem. So I just need to push a button here, go on Speichern. Thank you very much. And now I can go on backup recording on this computer. Thank you. Okay. Here I am back to see you. Okay, so what I want to do now is just go back to the basic ideas we were talking about last time before we go into more detailed ideas of the matter of, is it a sensory motor or somatic dysfunction, or is it an autonomic dysfunction we have. And of course, I cannot go into detail. We're planning here like half an hour of me talking about this issue, and then you can ask some questions, but I want to give you ideas. And that's what I think is one of the basic things to understand if we're talking about neurology, if we're talking about new ideas. It's first of all the system I have in my head. How do I think about this? How do I look at this? So a patient comes in and he has this problem, like, what are all the things I want to consider? And of course, neurology is always in the main focus, because that's the system that regulates the autonomics and the sensory motor system. The nervous system integrates everything. The nervous system is the system that puts all the pieces together and gives us a holistic view, a holistic approach. So integrated approach, holistic approach, all of that is, in my view, is neurology. So that's why I chose neurology to be the main viewpoint I have. But of course, I'm aware of that. Maybe people have to change their diet. They have to change the way they live their lives. They have to watch out what they do, what they put in their mouths, what kind of toxins are in there, maybe that they don't have to chelate to get them out again and stuff like that. So a whole bunch of aspects beyond neurology. But of course, for me, neurology is the basic aspect I'm looking at, because it has the opportunity to look at all these different aspects under one aspect of functional neurology. So what did we do last time? We talked about the 6 levels I want to consider. I always want to consider a local level. Let's say a person comes in with a hip problem. So what kind of receptors does he have in his skin, in his fascia, in his muscle, in his tendons, in his joint, in his arteries, in his lymphatic system? So here we already peeking into the autonomic functions that are associated with that. So I want to know about all the structures and all the nerves that are in those structures. How is their function? So of course, when I'm talking about a local aspect of receptor function, this is never going to be local, because as soon as I touch a part of the body, I'm activating the receptors. I'm also activating the nerve. I'm activating the spinal cord. I'm activating the brainstem on all these other levels we talked about last time. So yes, and I'm very aware of the fact that when I'm saying I'm working with the receptor, with the receptors in the periphery, I'm not actually working with the receptors. I'm working with the nervous system through the local receptors. That's what that's how you should call that. Okay, so. That's what we're talking about. Local receptor activity. Does the brain understand light touch? Does the brain understand vibration? Does the brain understand heat or cold? Is that all understandable? So that was the first level of the receptors. Next level was the nerve going to the spinal cord. The nerve conveying the information from the periphery to the spinal cord and vice versa. So information going from the spinal cord to the peripheral system. And of course, the nerve has a function. It has an electrical function and has a mechanical function. When I move my body, my nerves have to move. So that has to be part of my proprioception. My nervous system has to be part of my proprioception. My brain has to know, where is my nerve and what is it doing? Is it under stress or is it just doing fine? How is the supply, the blood supply to the nerve? So there's a whole bunch of aspects about the nerve, and we're going to be talking about that at some point later. I'm going to show some aspect how that can be actually tested and how we can work with a nerve function. Okay, so next level, spinal cord integration level, not just information, not just a bundle of nerves going together to the brainstem where it's going to all be processed. No, it's going to be processed in the spinal cord. So what's being processed? Well, different aspects in that segment. So we have muscles, we have agonists and antagonists. We have muscles on the right and muscles on the left and in the front and in the back, if we're talking about a sensory motor system. And these have to be coordinated. And of course, the system or the way the muscles are functioning, that's not coming from the brain in the first instance, that's coming from the spinal cord. So we have these gate pattern generators or central pattern generators that are sitting in the spinal cord, and they're giving a certain pattern to my musculature. So when I'm walking, The walking, the gait pattern is not coming from my brain, it's coming from my spinal cord. And what my brain is doing, it's coordinating it, and it's giving it a meaning or a motivation or a purpose. Where am I going and why am I going there? So, and also stop and go. So I can decide with my brain if I want to start and go, but my brain is not generating that pattern that I can see when my legs are moving. So function in the spinal cord is very important. We have maybe mechanical aspects there, but we also have, again, biochemical aspects there. So we have blood supply. An enormous blood supply to the spinal cord. If you look at pictures, anatomical pictures of the blood, the arteries and the veins in the spinal cord is just massive. So just looking at the spinal cord with the nerves coming out, yes, but look at a picture with blood supply. It's massive. Why? Because there's a lot of computation going on, and that takes up a lot of energy. So does that work? Is that working? Do I have a good blood supply? There's this theory about multiple sclerosis where they're doing operations on the veins because they're saying it's a problem in the veins of the spinal cord. I don't see that working very well, but I think the idea is interesting because, of course, the supply to the nervous tissue in the spinal cord is very crucial for good spinal cord function. Okay? So we might have, and that's a point we'll be getting to again and again, we might have a sensory motor problem in the periphery, but it could be an autonomic problem in the spinal cord. So is that something we can test for? Is that something we can differentiate, saying, well, is that hip or leg dysfunction now just an information problem from the vestibular system or from the eyes, just not conveying the information in which direction I want to move, or is it a problem of the processing of the information, and that might be due to the problem of supply, of oxygen supply, of glucose supply, etc. So that's one basic idea we're always looking at. What is the problem here, and at which level is that problem occurring? So next level we talked about was the brainstem, and like I said last time, I include in the brainstem the medulla, the pons, the mesencephalon, and the cerebellum, even if that's not the classical nomenclature. So I'm using that simple term, brainstem. That's what we're talking about at the lower brain level. Very integrated in terms of body physiology, whether it be movement or whether it be blood supply or blood flow. So all of that is happening in the brainstem, very integrated level. So how does movement in my leg affect the blood supply to my arm? When I'm running, I need more blood in my leg than in my arm. So that needs to be shunted to my leg. So that's probably what the brainstem and also peripheral systems are doing to regulate that. So the top of the brainstem, mesencephalon, already goes into like an integration between like the more complex aspects of motivation or exteroception. What am I seeing and what do I want to do with that? So it's like a connection hub between the physiology of the body and the motivational or exteroceptive systems with my goals and with what I see and with what I think about it, etc. So that's kind of like going away a little bit from the physiology of the body into the integration of the physiology with what's going on in the top of my head and my thinking. Before we go to the cortex, we have the part of the brain, the midbrain. I say, well, midbrain, some people always say the mesencephalon is the midbrain. We use the term midbrain for the parts that are between the brainstem and the cortex. So midbrain includes hypothalamus, includes hippocampus, includes amygdala, and there's a lot of evaluation going on there. So this evaluating the situation, not only in terms of bad, but also in terms of good, useful, not or safe, not unsafe, etc. So like the amygdala, some people say it's the fear center. Well, no, not really. It's just an evaluation center saying, could I get harmed or could I not get harmed? Is it safe or is it not safe? It also lights up when the situation is safe, especially when the situation is new and needs to be evaluated for the first time. That's one thing, where the amygdala is very active. And so it's a lot of evaluation and then, of course, storage. So when I meet some person I've met before and my first evaluation was good, I probably will just go towards that person, shake his hand or whatever I want to do. And that will just be okay if my first encounter was bad, was aggressive, or was not really sympathetic, then I might want to take a right turn down the next alley and get out of that person's way. So that's what's happening in the midbrain a lot, is evaluation. Of course, that also goes into motivation. If the situation is not good, I'm motivated to go away, or I'm motivated to go towards it, or I'm not motivated to go towards it. I'm dismotivated, I could say. And a lot about remembering, when did I meet that person that was not very nice to me, when was that, where was that, and how was he behaving. So a lot of storage about memory, hippocampus, the gateway to memory, that's also there. So there's a lot of memory and evaluation going on in that midbrain. I don't want to call the midbrain the emotional brain, because emotion is a lot more complex, and that includes a lot more areas, brainstem and also cortical areas, but we'll be talking about emotion at some other point. So then we have the cortex. Of course, the cortex is a very large and not very thick, but a lot of neurons, a lot of computation going on, very detailed computation. For example, about vision, I can see very detailed with my cortex, because there's a lot of neurons processing vision, especially in the back, processing vision, processing auditory, processing smell, more in the temporal parts of the brain. So a lot of processing about what's going on right now around me. So that's one thing they can do, is what am I paying attention to, and why am I paying attention to that, making decisions. I want to look at this and not at that. So that's a lot of the brain. What we always need to remember is that we have a look onto the brain systems, and we're going to be talking about that. Also, we might say phrenological view onto the cortex systems, in terms of the visual cortex is there for vision. Yes, it is, but it can also be there for sensory, for processing sensory information coming from the body, like tactile information. Like if you give a person that can see, if you teach them how to read, how do you say that in English? Braille, the writing for the people who can't see. And you let them open their eyes. While they do that, you can see the tactile information being processed in the sensory system. If they close their eyes, that sensory information is also processed in the visual system, in the visual cortex. So what the brain is doing, it's just giving it more computational space in the brain, which makes a lot of sense, because when I close my eyes, why should I not use that part of the brain for something else that I'm doing? And that's what we're all doing. If you, next time when you want to feel something and then you catch yourself closing your eyes, that's to give your fingers more computational area in your brain. That's what it is. So we have to be very careful when we talk about brain areas, that they do this, and this area does that, and this area does that. That's always true for a certain context or for a certain situation, but it's not always true. So visual cortex is not always or only for visual processing. So that's probably true for a lot of other areas too. Visual system is well looked at in terms of that called neural reuse. So there's a lot of research going on about that, and it's probably true for other parts of the brain too. Quite sure that parts of the brain are hardwired, like the systems that are driving breathing or heart rate. The center for breathing is probably not just going to turn into a center for, I don't know, touching something or something like that. So there's probably hardwired parts, or parts that are much more hardwired and much more static in their function and their parts of the brain, and that's probably the cortex more, that are much more dynamic. And what we should always remember also is that systems alone cannot do really a lot. It's always a network of systems that can end up doing a whole bunch of stuff, very complex stuff. So we have this default mode network, we have the dorsal attention network, the ventral attention network, the executive network, and so on. We're going to be talking about networks at some point. Very interesting. So, and that idea plays well into what we're actually thinking, what we're doing is connecting. So functional connectivity between not only the brain and the body, but within the brain, so the brain can function properly. And what is behind that functional connectivity? Probably a process called coherence, synchronization of different neuronal parts in the brain, and also neurons and body systems. So there's actually a synchronization process going on that can be measured, and that's the prerequisite for putting information from one place of the brain or one place of the body to another place. Same thing is happening here as we talk. So as we talk here, my camera hooked up to my computer synchronized over the internet with my provider, and then he's synchronized with you. So without that synchronization, you could not hear or see what I'm doing. So let me check here, everything is okay. If you guys want to write something in the chat, you can of course do that. I already said last time you can give me some ideas, you can ask some questions. I will not be able to answer all the questions, but I will go into the chat later on. But you can write me, and that's what I'm interested in topics, or give me ideas about topics you want to hear about in the future. So when I'll be talking again in 14 days, and every 14 days I'll be here. I don't know if you guys will be here, maybe yes or maybe not. Depends on how well I perform today. Okay, so here we are with the networks and with the synchronization. So that's probably one thing we're doing when we're working with functional neurology. We're working with functional connectivity. So I always say to my patients, I'm the electrician. I'm looking at your electric system. I'm looking if there is like a bad contact between the different parts, and we need to reconnect those, and we need to reconnect the networks in the system so they can function properly, and then the body function can be better than before. One aspect, of course, we already talked about is neuroplasticity, but we'll be talking about that later. That's the training aspect, and once we have better functional connectivity, we automatically have probably, I need to say probably because we don't know, probably have better neuroplasticity. At least that's what I see. Like when I treat somebody and then the muscle, which has been, has a certain grade of atrophy after an injury or something, is coming back, is growing back. Although they've been training and training and training, the muscle won't come back. And then you integrate them, and then the muscle comes back to its normal function and normal size, or better size. The way the muscle is in its size, we know from like fractures of the arm, when you have a muscle atrophy, you also have brain atrophy in the area corresponding with that broken part, and that's probably the same thing here. So that's happening after reconnecting. So training can be very useful. Explicit training can be very useful to train certain parts of the brain. But I believe, first of all, you need functional connectivity. You need a synchronization for that to happen. So those are our 6 levels: receptors, nerve, spinal cord, brainstem, midbrain, and cortex. And now the question is, somebody comes in and maybe has a hip pain or a knee pain or something like that, and you're asking yourself, well, what is going on right now? So what's the problem? Does he have a sensory motor problem? Does he have a biochemical problem? Does he have a biomechanical problem? So what is the criteria? What do I need to think about? What do I need to look at? And I want to just give you an overview of what I think and the patterns in which I think when I look at a person like that. So somebody comes in, classical idea might be, well, he's got a hip problem. I'm doing some muscle testing, see if his rectus femoris is working, or I'm doing some watch him walk, and I see the biomechanics are a little bit off. The pelvis is not really stable. I'm thinking like muscle. I'm thinking muscle function, and maybe I'm thinking more sensory motor. So maybe there is some kind of information that the muscle is not getting from the central nervous system, whether it be from the spinal cord or from the brain. But let's maybe assume that there's a disconnection between, or a bad integration between the vestibular system and the sensory motor system. And the vestibular system is very crucial for me to walk upright and to walk in a straight line. So maybe I have a dysfunction, maybe caused by head trauma. Or a neck trauma or something like that, and my vestibular system and my sensory motor system in the periphery is somewhat disconnected. So I'm looking at the function of the vestibular system. So I'm still thinking in terms of information. If I'm turning my head and the rest of the body is not getting that information that the head is being turned, I might have a problem getting the right muscle to work at the right time to match that movement of the head. So I'm turning this way, or I'm turning that way. So that's very crucial. So that could be a functional connectivity problem or a coherence problem. Just information is not transferred. What is the information in the system. It's electricity in the first place. It's action potentials, and it's synchronization patterns that are measurable, that are electric activity in the nervous system. So to me, when I'm talking about a information problem, I'm talking like about an electric problem. Okay, so that could be one part of the picture. So now I have this dysfunctional muscle, and let's just walk through this in a very overview way to look at muscle function. Let's say the rectus femoris is not facilitating correctly, and if it's not facilitating correctly because there's some certain information that's not coming down, I might want to find out how I can facilitate the movement of that muscle. But a lot of people I watch doing muscle function tests only look for facilitation. So is a muscle strong or weak? Well, for me, that's only one part of the criterion. So I have like 3 criteria. Does the muscle facilitate? Does it get strong? Number 1. Number 2, does it get weak? Can it get weak? Can it inhibit? Can it be inhibited? Because movement is activation, inhibition, activation, inhibition. So that's very crucial for a muscle to find relaxation. So like here I have this patient, and he fell on his shoulder like 2 years ago, and his shoulder is still not moving correctly. He's trouble raising his arm. So we're looking through all these aspects, and all the muscle in his shoulder all are working fine in terms of facilitation. So they facilitate, they get strong, no dysfunction of a muscle in terms of a weak muscle. So we start testing for inhibition. And there you could see that there's several muscles, I don't remember which one they were exactly, several muscles not being able to inhibit. That's like a tract going mostly to the cerebellum. So that's the spinocerebellar tract, which can be affected or which can be the problem. And it can just be a connectivity problem between those systems. So then you can, for example, through neurofunctional integration, you can reintegrate those systems to work together better. So how we're going to do that, we'll be showing at some point. Now it's just the basic idea we want to talk about. Okay, so inhibition, facilitation, inhibition. 3rd, integrated function. So who tests for integrated muscle function? What does that mean? So how does the muscle behave? Because a muscle can be activated correctly, can inhibit correctly, and I'm now talking about a patient, he's lying down, he's on his back, and I'm doing the classical muscle testing. So everything is fine. Is the muscle fine? Could be that the muscle is not understanding what other parts of the body are doing. Now we're back into that integration part for example, vestibular system. So does the muscle understand that he has to act differently if I turn my head to the right than if I turn my head to the left? So it's a different pattern. You can see this pattern in babies. When you take a baby and you turn the head to the right, they get this kind of pattern. They get an extension on one side and then a flexion on the other side. So the flexion is always on the side away from the rotation. And so that's a movement pattern. We call that a what do you say that in English? How do you say that in English? Frühkindlicher Reflex, we say in Deutsch. So it's like a baby reflex. I don't know if that's probably not the right term. It's like a baby reflex, and we think that those reflexes go away because at some point when you turn the baby's head, he's not going to react like that anymore. But that's not true. That's absolutely not true. The reflex is not going away. Every person has that type of reflex. The only thing is when I have an adult lying on my bench and I turn his head, he's not going to go like this, okay? But you can see it in the muscle function. You can see the way muscles are facilitating and inhibiting. So that means when I turn my head to the right, that muscle better relax because I need a extension here so I can have a pivot point, a point of turn, so I can turn my body over that. Okay, so that's what you see. You can test that. You can't see it by just turning the head, but you can test the muscle function. It's going to change by the movement of the head. That can be caused by proprioceptors in the neck. It can be caused by the vestibular system, for example. So we're going to be talking a lot about movement patterns because that's one of my main issues. One thing I worked on over the past 5 years a lot. Basically no real, I didn't find any real literature on that. So there's a lot of things that still need to be explored. And every day I find more patterns going on, more basic patterns coming from ligaments, etc. So that's very interesting. So movement of the muscle, etc. So that's all very sensory motor thought. But what if that problem has no sensory motor problems. So you're testing for movement patterns, you're testing for muscle function, and there's nothing really going on. You're testing the proprioceptors in the hip joint, you're testing the proprioceptors in the knee joint, all that stuff. Everything is fine, but still the patient is complaining of a problem in his hip. So now maybe the questionnaire is going to be a little bit, is going to give us some information, because maybe that person said, well, I had a head trauma before I got my hip problem. So what's going on in head trauma? So maybe we have a disconnection, but maybe we have an autonomic problem in the brain now. So here we have these systems in the brain, the cerebellum, also the motor system, the sensory system, that are responsible for movement. Now after the head trauma, and we know that after head trauma we do have reduced blood flow even after minor head traumas over a longer period of time. So now we don't have a sensory motor problem as the initial problem in terms of electrical problem. Now we have a problem of maybe blood flow in the brain, giving the brain the things they need. It needs oxygen, glucose, etc., to work properly. So how could that show clinically? Maybe not stepping on my hip and it hurts. When I step on my hip like this, it's fine, but I start walking for a longer time, I start running, I start jogging, then my hip starts to hurt after like 10 minutes, 15 minutes. That could be a hint towards more autonomic problems. And yes, this autonomic problem could be right here because we have a blood supply right here. But while I'm moving my leg and while I'm using my muscle of my hip, and this needs information to work properly, and also needs a blood supply to work properly, oxygen, glucose, all that stuff. We have that here. At the same time, we have a computational system here in the brain, for example, up here, motor system, sensory motor system, and this part of the brain, while it's computing, also needs oxygen. So we have information here, we have information here, we have blood flow here, we have blood flow here, if we want to reduce it to blood flow. So this is what we need to consider. Not only local blood flow, but also blood flow in the brain. So we've made some, I think, great progress now, getting more into a differentiated diagnostic to see that if the dysfunction in the head, what type of dysfunction that is. Because when we go here and we say, well, this is where the motor cortex is, well, there's also skull, there's also blood vessels, there's also lymphatics. So we know that there's lymphatics in the skull and in the brain now. So if that's not working properly, how could my brain work properly? So we need to be able to differentiate between just like a connectivity problem and a local blood flow problem or a supply problem of the brain. We should be able to diagnose that. That's what I want to say. So let me just go here on Instagram. I'm just gonna say hello, hi. Thanks for watching. Say I was Michi. Hi. So we have maybe an autonomic problem in the brain causing a sensory motor problem in my hip. Okay? So the sensory motor problem is not the problem. The sensory motor problem is the complaint, or is the secondary problem. Yeah. So the primary problem is maybe the blood flow problem of the brain. So the questionnaire or the talking to the patient would probably reveal where I need to look at more. Should I look more at the hip, or more at the back, or more at the brain, or at the head? And then the testing should reveal if I'm just having like an information problem, or if I have a blood flow problem, which of course is also in the end an information problem, just on a different level, in the more autonomic level, saying, well, that part of the brain now needs more oxygen, so we need to supply it with more oxygen because it's using all its oxygen to move the hand or to move the hip. So we should be able to differentiate that. And yes, we can, in my view, differentiate that now in a way that through our testing to say, well, we need to kind of exclude arterial or lymphatic problems or cranial problems, and if there's nothing there that gives us a hint towards an autonomic problem in the head, then we might think more, well, it's just an information transfer problem, a synchronization problem, or an electric problem between the head and the body. So that's the idea we're always looking at, saying, well, is it just information, or is it supply of the system that's working with information? Yeah, like a computer. All these all this data that's being transferred is going through some server somewhere sitting in a big room. What does that room have? It has a cooling, it has electricity. If the electricity is off, if the power goes out, no more information transfer. So I can have a problem in my power supply at the server, or my heating or cooling at the server, and that will impede my information flow. I can also have a mistake in the information itself. So the information being processed may be wrong, or maybe may have too many mistakes in it. And the power supply is fine, the cooling is fine, but the information is just bad, and that's why the rest of the information is also going to be bad, or the results of that computation is going to be bad. So that's the way we always have to think about this. And this can happen here. In our brain. It can happen, of course, in between. It can also happen here. So I said we have muscle here. We need to look at the muscle function, but we also have blood supply here. So here's a patient coming in having hip problems. So you look at him, you do some muscle function tests, you look at the gait pattern, you do all these things, you do some sensory testing. Everything looks okay. You do some vestibular testing. There's no real thing. He also did not have a head trauma, but what did he have? He maybe had a diagnostic of his heart, Herzkatheter, we say in Germany. So you put not a camera, you put in well, sometimes they put a camera up there. You put an electrode up there, or whatever, to do something in the heart, and you go through the femoral artery. So that causes some irritation. You cut that open, you put a tube in there, and then you sew it back in, and then you compress it. So we already had a few patients here in our practice complaining of some kind of pain, knee pain, hip pain, back pain, after a diagnostic procedure like that. So that's not a problem of the motor system or the sensory system. Maybe it is of the interoceptive system. It was, in their case, or in those cases, it was a problem of the arterial system. So there was an irritation in the artery, maybe causing a lack of adaptation in blood flow, then causing maybe a bad muscle response or bad muscle function in terms of, well, when I walk longer, I start feeling pain in my leg or in my hip. Not because the mechanics is bad, because the computation is bad, because the brain is not putting sensory motor and vestibular issues together, but because the blood supply is bad. And that's, of course, what we need to find out. So we need to be able not only to test muscle and fascia and ligaments, we need to be able to test the vascular system. We need to be able to test the lymphatic system. And what I want to say here at this point is that in my practice here in the south of Germany, in my function, in my property as a medical doctor, I see a lot more autonomic problems, way more autonomic problems than I would say as classical sensory motor problems. So whatever I work with the head, with the spinal cord, with the hip, with whatever it is, very often when I start integrating it, I end up in the autonomic nervous system. Maybe in 80% of the time. So that seems like a lot, but of course I'm having these patients who are coming in and saying, well, I have this knee pain, I've had this for 3 years, and I don't know where it's coming from, and I don't know why it's there. And so we need to consider these, besides these sensory motor aspects, we need to consider the autonomic aspects. And why is maybe autonomic more prevalent? Maybe because autonomics is more important. The blood flow to my leg might be more important than the information flow. If I have a bad information flow, I might get to be 105 years old. If I have a bad blood flow to my leg, maybe I'm gonna die earlier because I have some problem then with metabolism and then whatever it's going on. So I'm pretty sure that in the hierarchy of what's more important, blood flow, oxygen supply is more important than vestibular information to the muscle. Of course, vestibular information to the muscle is very much needed for precise movements, but autonomic is more crucial. And that's why I think, and that's what I do actually, is I always look for autonomic dysfunction first. And I look for autonomic dysfunction in the leg, in the body everywhere, and of course in the brain. And I'm very happy because that's been a great progress that we're now, through the way we test, we're now able to kind of look at more differentiated aspects of autonomic dysfunction in the head, in where the brain is located, to get an idea that this is not just a computational problem, it's more an autonomic problem, doing the supply, giving the system oxygen, the brain oxygen through the lymphatics and the venous system, getting all the dirt, I want to say, get all the dirt out, no, all the garbage, yeah, bring out the garbage, of course, very important. So that's an aspect we look at, or I look at first, because I think it's more important. And what's left over might be just sensory motor information transfer problem, synchronization problem, and yes, there's probably a lot of that also, but I see way more, or I look way more into the autonomic system, which concurs, or which agrees then with like what the traditional Chinese medicine guy is saying, oh, it's the liver. There's reasons why liver is important for the muscle function. There's metabolic reasons, but of course there's also like anatomical reasons why that might disagree with one another, not because the bad metabolism of the liver is causing the muscle dysfunction, but the bad circuitry in the autonomic nervous system, and we're going to be talking about segmental anatomy at some point. It's very important to know about that, is causing like a interference between those systems. So there's different aspects also to think about there. Okay, so this is what I wanted to give you an overview again of what we talked about last time, and then of course this idea of this very basic idea of thinking about the autonomic nervous system more. A lot of people probably already do that. I think if you're coming from like more biomechanical background, maybe osteopathic background, chiropractic background, maybe you're not thinking about it enough. Probably more and more is coming into all those things, and we're just trying to give it a system in which we can see what do we need to consider local, on a global level, and a local brain level, and a local peripheral level. What are our considerations about information that's needed for proper muscle function in terms of vestibular information, for example, or blood supply, or getting rid of lactate and stuff like that through the lymphatic system, through the venous system, etc. So all of these aspects are important, and we need to consider everything, and functional neurology, in my view, gives us the opportunity to look at all these different aspects. Okay, so I'm going to start talking at this point, and I'm going to say bye-bye, and thank you very much for watching on Instagram. I'll be back in 2 weeks, and yes, you can also join us on Zoom. Zoom link is always on our website on the first page. There's like a green bar, and we have the link in there, so you can register on Zoom, because then you have the possibility to chat with me directly, which is what I'm going to do now. So I'm saying thank you for watching. I hope I have some information, had some information for you, and I'm sure I will have some good information for you in the future. See you later. Have a nice evening, and thank you. Bye-bye.